So, hello everybody. Could you let me know, any one of you, that you can hear me? Just write me in the chat. Great. So, let me see and tell me, could you see the presentation? No. So, let me just fix that. Yes, yes. Now yes, now no. Okay. Just give me a second. I have to fix this because now I cannot damn it. Okay, we do it this way. So, now you should see it. Do you see it? Great, cool. Cool. So I hope everybody is here. I'm sorry. Okay, let me switch on the camera so that you can see me, even though there's nothing great to see. Cool, should work now. Great, great. Okay, there's one more coming. Great. Okay, so we have some 45 minutes to talk today about basics of acid-base balance disorders. So what I'm going to go through with you is to give you a kind of a brief overview of what are you supposed to know about acid-base balance disorders, let's say from the clinical perspective. Before we get to the presentation itself, if there is any comment of you, any question, just chat it to me. I'll read it. If it is relevant, I'll answer immediately. If not, I'll try to answer. I'll try to answer in the end. I know that it's very difficult for you now with all the situation, but believe me, it's also very difficult for us as we are quite overwhelmed with a lot of clinical duties right now. So we are going to go through these learning objectives, and we get immediately to the point. pH, or acid-base balance, is one of the vital functions of the organism, or better to say, the whole milieu interieur is the vital function. Therefore, the organism has to retain or maintain acid-base balance in a very strict and narrow reference ranges, and for that, the organism uses what is pH? You probably know it's a decadic logarithm of concentration of protons. So you may see pH as a kind of proton load that is in organism, and to maintain pH in this very specific range that is optimal for enzyme and cellular functions, the organism uses various so-called buffer systems. There are quite few of them. Sorry, let's accept another one. There are quite few of them, but the major in terms of buffer capacity and in terms of sorry, I'll just answer the phone here. I'll put it somewhere else so that it doesn't ring here. Okay, I'm back. There are quite few of these buffer systems. Among others, let's say we have cells. Every cell actually tries to maintain the optimal pH gradient in between extracellular and intracellular space. Therefore, when there is a shift in pH in extracellular compartment, the cell switches protons in exchange with potassium cations to maintain optimal pH or optimal gradient pH. We have phosphates and sulfates that can actually accept protons, and we have also albumin negative charges or any plasma protein negative albumin charges. And the last one, but the least one, is bicarbonate buffer. Bicarbonate buffer is not the most important concerning the buffer capacity, which is approximately 50% of the whole plasma capacity, but it is the most important in terms of being an open one. What does that mean? What does that mean? If you see here we have bicarbonate. If you can look at as bicarbonate and being a conjugated base, and then you have carbonic acid and carbon dioxide as being conjugated acid, you may very well see that on the both part of the equation, you may the organism may adapt these variables. Therefore, that is why it is open, that the organism can regulate both the amount of conjugated acid via minute ventilation. Therefore, if you increase minute ventilation, you decrease partial pressure of CO2 and you increase pH. And you may also regulate on the other side of the equation the amount of bicarbonate by increasing or decreasing its reabsorption in kidney. Therefore, we have okay. Let's accept another one. So you have kidneys here, nice kidney, and you have lungs. Therefore, you may regulate both sides of the equation, and you may adapt according to need of the organism. That is one important point. Another important point is that when talking about acid-base balance, we rely with its classification to the interpretation of this bicarbonate buffer. And when we talk about acid-base balance disorders, we talk about bicarbonate buffer. Therefore, we classify the major disorders, the major acid-base disorders, according to this buffer sides of the equation, as being primarily respiratory disorders. So this is respiratory. So this is respiratory part of the equation, and as being metabolic disorder. Do you see my drawings? Do you see my drawings there? Could anyone write me down that you? Great. And the other side of the equation, where you have bicarbonate and proton, we talk about as metabolic disorders, where if the primary problem relates to that side of equation. Okay, great. The relationship in between bicarbonate and partial pressure of CO2 is actually shown in Henderson-Hasselbalch equation, which you may see up here. And this one you remember very well. You do not need to remember the whole Henderson-Hasselbalch equation, but you remember that to be able to interpret blood gas analysis report, you need to remember a very simplified version of this equation, and that is that pH approximates bicarbonate over CO2, PCO2. That is the important point. With this knowledge, you are able to interpret almost all primary or compensation and a majority of complex acid-base disorders, as we'll see in the next step. So far, any questions? If there are any questions, just write down. If not, do not write anything. Let's move on. So, according to shift of pH, we have pH going up, meaning alkalemia or alkalosis is a trend toward shifting up. Then we have trend towards shifting down, which is pH low, which is acidemia or acidosis. And according to let's move back. And according to the primary problem being either in minute ventilation or either in reabsorption or retention of bicarbonate, we have either respiratory or metabolic problem. So we have this combination of four disorders, and let's get to the respective disorders. So we start right now talking about respective primary disorders. We start with metabolic alkalosis. Now you look at the lab results you see at the screen, and I'll show you how to approach towards these results. First of all, when concerning acid-base balance, we look at these variables, okay? And first of all, we look at pH. pH you have here. So we look, it's 7.5, let's say. So pH is high, okay? So pH is high. Then we look at PCO2, okay? Just remember, pH, PCO2. We look at the PCO2. PCO2 is low. You may see reference ranges here, okay? So we have low PCO2. Then we look at bicarbonate. Bicarbonate is normal. So bicarbonate is normal. So does it make sense? It makes sense. Low PCO2 produces increasing pH. What's the situation? The situation is when you hyperventilate. When you have hyperventilation, so-called hyperventilation syndrome, you increase your minute ventilation. When you increase your minute ventilation, you decrease your partial pressure of CO2, and therefore you shift your pH up and you cause yourself a respiratory alkalosis. Okay. Concerning respiratory alkalosis, you remember that you cause it by, or it's connected with hyperventilation syndrome. But to see what is the cause of the hyperventilation syndrome, the major cause is panic attack. During panic attack, patients or people usually hyperventilate, and they can cause themselves a severe respiratory alkalosis. But hyperventilation syndrome, and you always remember that, does not necessarily mean panic attack. Panic attack and hyperventilation syndrome and panic attack is actually a diagnosis per exclusionem. So you need to exclude all other potentially life-threatening causes of respiratory alkalosis and hyperventilation syndrome, and that is, above all, meningitis and meningoencephalitis. It means neuroinfections. That is, anything that actually irritates brainstem. It can be intoxication with stimulating amphetamines, being it either Pervitin, amphetamine, or being it MDMA, ecstasy, etc. All these can cause hyperventilation syndrome. Inflammation and hyperpyrexia, it means fever, can cause hyperventilation and hyperventilation syndrome, and gravidity, pregnancy. Pregnant women may have tendency towards hyperventilation. So If nothing else, you remember that in the different, and then you have hypobaric hypoxia, of course, if you climb up to higher altitudes. But this is not something you would see in a clinic in a normal setting. So the only thing you remember that should be always the red light that shines is when you see hyperventilation syndrome. Think about meningitis, meningoencephalitis, neuroinfections, and think about intoxication with stimulating amphetamines. Okay, these are those that you should always remember before you conclude the patient is just having panic attack. What is the symptomatology of respiratory alkalosis, or generally any alkalosis you have, causes that causes decrease in, because to buffer for this alkalic load that you have in your plasma, albumin and other plasma proteins gets rid of any ions they have on their negative charges, bound to their negative charges, so that they can accept, so they can show off the negative charge. But basically, what happens is that in these settings, ionized calcium that is dissolved in plasma gets bounded to these negative charges, and you have decrease in ionized fraction of calcium in plasma, and therefore the symptoms of alkalosis are caused by hypocalcemia. It's ionized hypocalcemia. What is it? It is perioral and acral paresthesia and cramps, leading to something we call tetany, eventually opisthotonos. So that is something that actually augments usually this hyperventilation, because patients, they feel they have stiffness in their mouth, and they cannot move their limbs. Okay, so that is respiratory alkalosis. What is the treatment? And I tell you right now what's the general answer for any questions on treatment of acid-base disorders, and that is the treatment is causal. We treat the cause. We do not treat the associated acid-base disorder. In this case, we treat panic attack by giving patient benzodiazepines, or in home settings you can give a shot of whiskey, for instance. It works at the same GABAergic receptors, which is not advisable actually, but it may help. And you let the patient breathe to a plastic bag so that he recirculates he rebreathes his CO2. But we treat the cause. Of course, when the cause is intoxication with MDMA, then we treat the cause. If the cause is meningitis, then we treat the cause. Okay, so that was respiratory alkalosis. Nothing complicated. You get rid of your PCO2, you get high pH, you get symptoms of hypocalcemia. Okay, so let's move on. The next respiratory disorder is respiratory acidosis. Okay, it means the shift in pH in the very opposite direction. The results you see here are a bit more complicated, as the life brings usually more complicated things than just primary disorders. Let's go through it. First, let's look at the pH, which is very low. Then we look at the PCO2. So let's go on with this equation: bicarbonate, PCO2. So we have a low pH. Then we look at the partial pressure of CO2, which is high. That makes sense. High PCO2 can produce low pH. Then we look for bicarbonate, because we should expect that if we have primary change in PCO2, we would expect that bicarbonate would compensate for that change in terms of in terms of increase, that would be compensation, so that pH normalizes. So sorry, it goes in the opposite direction. Can I use Vergam? No, there is no. And just figure out whether I can delete something. No, I cannot. So this should go down, okay, as a compensation. Bicarbonate should go down so that the pH normalizes here. So the pH normalizes here. So we look for bicarbonate, which is here, and bicarbonate is a bit low, but not very much. So the compensation is not pretty good. And you may see quite well why the compensation is not pretty good in this case. It can be actually two causes. One is that the problem with low minute ventilation developed very quickly, and metabolic compensation usually takes 1 to 2 days to develop, so that you have to adapt your transportation mechanism in tubal in kidney. But the other problem that you may well see in this patient is that he's got a high, why does not work? Okay, high lactate, and high lactate is the very opposite problem. It causes metabolic acidosis. So you have this combination of respiratory and metabolic acidosis, and metabolic acidosis, on the other hand, can drive your bicarbonate. Yeah, it's another way. So it's a bit more complex in this situation. Let me think. Yes. So you may just omit this and just look at PCO2 and pH, so that we make it more simple. Is anything that decreases minute ventilation, and it can extend from brainstem. You can have, for instance, opioid intoxication with ventilation depression, central ventilation depression. You may have oblongata problems after trauma. You may have paresis of phrenicus nerve that could help breathing with your diaphragm. Then you may have, for instance, serial fractures of ribs. So anything that could affect your rib cage. And then, of course, you may have problems with lung parenchyma and extensive work of breathing during, for instance, extensive pneumonia. And the last but not least, which is probably the most common problem associated with global respiratory insufficiency, and that is any obstructive ventilatory disorder. It means, for instance, chronic obstructive pulmonary disease, or acute exacerbation of asthma. So these all can lead to retention of CO2, because you cannot exhale sufficient amount of CO2 because you have low minute ventilation. And you retain PCO2, and as PCO2 is here in our equation, it drives pH low. And as I said, the same applies to any acid-base disorder. That once you have a primary disorder, the other system in the open bicarbonate system tries to compensate for it. In this case, the compensation has just started, but it's not optimal. The bicarbonate is still high. But let's see what happens to our patient. Let's pretend this is a patient who comes with COPD exacerbation. You may see that his saturation in blood is low, so he's got definitely a respiration ventilation problem. But look what happens to him when we compensate him. now you have the same patient, and you may see that let's see here. His pH is normal in this case. His PCO2 is high. What does that mean? A high PCO2. The patient may have high PCO2 once once he's fully compensated. Let me see. Okay. Here we go at the screen. So we have normal pH, we have high PCO2, and normally high PCO2 would produce low pH, but in this case, you see that bicarbonate also increases as a compensation, which you may see here, so that it compensates for decrease in PCO2. Okay, and therefore the pH remains normal or get back to normal. So that is another rule that you should remember about analyzing acid-base disorders, is that normal pH does not exclude severe acid-base problem. Okay, in this case, you have a normal pH, but you have a patient who's got COPD, who's got chronic, fully compensated respiratory acidosis. Okay, so you see that the compensation is not partial, the compensation is full, because it compensated fully to normal values of pH. And this is actually a clinical scenario of a patient with chronic obstructive pulmonary disease, patient with chronic obstruction that is compensated. Okay, it's a chronic problem, and the fact that it is chronic, you see on the fact that his pH is normalized. Okay, but when he's got to a state of exacerbation, he would get back to this state where his pH drops down because PCO2 rises even higher. Okay, so these were respiratory disorders. Respiratory disorders are, I would say, quite straightforward, because you just look for PCO2, you see what changes in minute ventilation patient could have, and then you assess compensation in terms of bicarbonate. And you have respiratory alkalosis, which is hyperventilation, and respiratory acidosis, which is hypoventilation, low minute ventilation, and it equals global respiratory insufficiency. Metabolic disorders, on the other hand, cannot be interpreted by this very simple bicarbonate-centered approach, as you always have to rely, when analyzing metabolic disorders, on other minerals or other electron active compounds that you have in your plasma. So we'll get back to these Gamble plots or diagrams that shows us what are the negative and positive charges in plasma. You just remember for now that there are quite few electrochemical, electrophysical laws that applies when the organism lives, and one of these is that the amount of proton equals in plasma the amount of electrons, and this is depicted on in the column A, where you can see there should be also potassium, for instance, there should be magnesium, for instance, on the side of the positives. And again, somewhere here, very small, you have the protons, of course, but these protons are in nanomolar concentration, so therefore it's so few that count with absolute numbers does not make sense. So that's why we talk about protons as pH. Okay, but these are nanomolar somewhere here. So when analyzing metabolic disorders, metabolic disturbances, you always look for changes in minerals too. Okay, and according to these changes, we have also the classification of metabolic disorders, and we'll get right to it here. So look with me for the report we have here. So here we have pH, which is very low. pH is low. Then we look PCO2. PCO2 is low. PCO2 is low. Can low PCO2 produce low pH? No. Low PCO2, if isolated, produces high pH. It's respiratory alkalosis. So this is not the primary problem. So we look at the bicarbonate, which is here, which is very low. Which is very low. Could low bicarbonate produce low pH? Yes, of course it can. Low bicarbonate is the cause in this case. So therefore, it is metabolic origin of the disorder. Okay, the primary problem is here. This is primary problem. This is secondary compensation. Okay, makes sense. So this is metabolic acidosis. Metabolic acidosis are generally of two major types, and to differ in between these two types, we have to look on other minerals in plasma, as I said. And either you calculate something what we call an ion gap. An ion gap is all the electronegative charges that we usually do not normally assess, or we have limited access to possible analysis. And you calculate an ion gap. That is one possibility. And another possibility is that you simply look at chloride levels, because we are usually lazy in the clinical settings, so we do not calculate an ion gap, but we just look at the chloride levels. And this can produce two situations. Either your chlorides, which are here, are normal, as in this case, therefore the change, which you have low bicarbonate. Okay, we have low bicarbonate here. That is the definition of metabolic disorder, low bicarbonate. And low bicarbonate can be either due to increase in an ion gap or increase in chloride level. Okay, and therefore we have two major BC. We have two major. Let me see. We have a question here. If we do need to calculate an ion gap, will we take into account adjust for albumin? No, we do not. An ion gap normally is 10 to 12 millimoles per liter, and we make it that simple. There is some charges on albumin. We can actually analyze them, but for the primary setting of this acid-base model, I would advise not to go much in the detail and just to stick on the fact that an ion gap is 10 to 12, and if it is increased, then we have an ion gap metabolic acidosis, or so-called normochloridemic metabolic acidosis. And if your anion gap is normal and you have metabolic acidosis, then you have hyperchloridemic metabolic acidosis. Okay, so let's get back to our example. We have normal chloride levels, which means that the decrease in bicarbonate is caused by an ion gap expansion. And in this case, we may think about what are the causes of an ion gap metabolic acidosis. An ion gap metabolic acidosis can be caused by lactate, ketone bodies or keto acids, and phosphates and sulfates in renal acidosis, in renal failure. So these are three possible causes of so-called endogenous anion gap metabolic acidosis. And then you have a fourth possibility, and that is intoxications. It means there is strong non-volatile acid introduced to your organism. It can be, for instance, ethylene glycol. It can be formaldehyde in methanol intoxication. These are the most common, and that is all. There is nothing more that can be there. Lactic acidosis is a shock state. Ketoacidosis is associated with diabetes ketoacidosis, and renal acidosis is caused by renal failure. It's clear. Then, on the other hand, if you have a normal anion gap and you have high chloride levels, this case, you can the cause of this hyperchloridemic metabolic acidosis is due to decrease in bicarbonate level, and you lose your bicarbonate basically via two possible routes. One is GI tract. If you have loss of proximal jejunal or pancreatic juice, which is alkalic, then you may have extreme losses of bicarbonate, and that could produce metabolic acidosis with high chlorides. That is pancreatic fistulae or profuse diarrhea. The other cause of loss of bicarbonate can be via kidney. Again, you have a nice kidney here, via kidney, and this is the whole big group of tubular disorders that we call renal tubular acidosis, okay, RTAs. I will not get much into details as we run out of time, but these are basically two major causes of hyperchloridemic metabolic acidosis. So here we revise the case. In this case, to be honest, we may look at the lactate just to dissect the cause from, even though we do not see the patient. Lactate is 4.7, so this can somehow relate to it is increased. So there is some hypoperfusion and some incipient or imminent shock state, and you have high glycemia. Though we do not have ketone bodies here, we may expect that these patients may have diabetic ketoacidosis, which was the reality actually. So, and the last disorder we are going to talk about is metabolic alkalosis. Metabolic alkalosis. Again, metabolic alkalosis as a metabolic disorder, we have to look for minerals in plasma to be able to classify it and analyze it. If we look at this concrete scenario, again, I draw you this PCO2 bicarbonate. This equation, we have a high pH, then we have high PCO2. Could high PCO2 lead to increase in pH? No. This must be therefore compensation. So we look at bicarbonate, which is here, it's 52, so it's increased, it's very much increased. So the primary problem here is increased bicarbonate, and therefore we have metabolic primary disease is metabolic alkalosis with partial respiratory compensation. Of course, you cannot compensate metabolic alkalosis very much with CO2 retention, because you could cause yourself hypercapnic coma. So you cannot completely compensate for that. So basically, in what are the two possible scenarios? Again, we look at chloride levels in this case. Either, as in this case, you have low chloride levels, and therefore we have something what we call chloride responsive metabolic alkalosis. I know the term is maybe a bit strange, but it's the term. Chloride responsive metabolic alkalosis that is caused by loss of chlorides, basically, in majority of cases, by losing gastric juice, either by extensive vomiting or by some gastric drainage. So that is this case. You may see very low chloride levels that causes this chloride responsive metabolic alkalosis. In this case, saline is a treatment of choice. On the other hand, as you may see in this case, high pH, high PCO2, and very high bicarbonate here. So the very same scenario, but in this case, you have a almost, let's say, a bit low, but almost normal chloride levels. So that is something we call chloride non-responsive metabolic alkalosis. And chloride non-responsive metabolic alkalosis is usually caused, a majority of causes are due to hyperaldosteronism. What does aldosterone do? You probably remember that it retains sodium in exchange of potassium in kidneys, but also it exchanges not only for potassium but also for protons. So it leads to losses. When you have high aldosterone, it also leads to loss of protons into the urine. So once you have hyperaldosteronism, you have also, and it's a very typical scenario, you have chloride non-responsive metabolic alkalosis, meaning that you have a normal chloride levels. Okay. And again, what is the cause of? So you remember hyperaldosteronism, and then we may talk about what is the cause of hyperaldosteronism. Primary hyperaldosteronism can be caused by producing adenoma, but again, much more common is secondary hyperaldosteronism, and that is related to anything that decreases perfusion of kidney and therefore decreases production of renin. Majority of cases is heart failure, liver failure with liver cirrhosis, and nephrotic syndrome. So these are all three edematous states with paradoxical low perfusion of kidney and secondary hyperaldosteronism. And you probably remember, or you probably know that you should know that we treat both in liver failure and in heart failure, we treat this hyperaldosteronism using aldosterone antagonists, spironolactone. Okay, great. So I think that our time is over, and that is actually the last slide. So what do you remember? What are the major take-home messages? Blood gas analysis is a complementary examination. So you first look at the patient, get patient history, and then analyze acid-base balance, because as you saw, there may be disorders where your pH is perfectly normal. So first look at the patient, then look at the lab results. All the acid-base disorders have their underlying cause, and when talking about acid-base disorders, is talking about its underlying causes, and the same applies to treatment of acid-base disorders. So, are there any questions? Let's give some 1 minute for question. If you write me to chat something, I may answer. Otherwise, I think there's another lecture going on. If you give me some feedback, because it's very difficult for us at this time learning with e-learning, I would appreciate that. I see there are some 18 of you, so that's great. It evaluates itself. So I wait for a while for questions. Okay, if you write me down whether this Adobe conference is better than YouTube channel, you can also write me down. Thank you. Okay, great. Okay, if there are any questions, you feel free to write me an email. I'll try as much as I can to answer, and I wish you a good luck, and fingers crossed we overcome this very soon. Bye.